Good morning. It is my pleasure to present this lecture or this course to you. Thank you, Leyla, for giving me this opportunity. Let me introduce myself first. I am Gülnihal Kutlu Günergin. I graduated from Hacettepe University in 1995. I'm currently working as a neurologist and clinical neurophysiologist at Muğla University. My interests are epilepsy and sleep, and today we will talk with you about anti-seizure medications or drug therapy in epilepsy. Now I try to share my screen. Okay, I hope you see my slides. As I told before, now we will discuss anti-seizure drug monotherapy in epilepsy. As you know, epilepsy is a common neurological disease. It can be seen in any ages, in newborns or in older ages, any ages. I am sure that you remember the epileptic famous people. These people have epilepsies in history. And the main way of treatment, as you know, anti-seizure drug. It's the milestone, and greater than 95% of patients with epilepsy use anti-seizure drugs. And there are some other treatment options like epilepsy surgery or diet, especially the ketogenic diet, and nerve stimulation methods like vagal nerve stimulation, and we perform to patients vagal nerve stimulation in our center. And also another way for nerve stimulation is repetitive nerve stimulation. It's available only in US. And another option is deep brain stimulation. It can be possible in European countries and US. And the cause of epilepsy, the cause of seizure is also very important. We should eliminate the cause and facilitating factors, if possible. For example, patients come with seizure and hypoglycemia. First aim is to correct hypoglycemia. As I said before, anti-seizure drug is the milestone of treatment. Greater than 95% of patients were treated by anti-seizure drugs. And now, today, we will discuss these drugs and therapy. And there are many anti-seizure drugs. We know that from 1870, we have some drugs, but in last 20 or 30 years, many new drugs are usable for us. And first column is conventional anti-epileptic drugs such as phenytoin, phenobarbital, carbamazepine, valproate, or pyrimidone. And there are some new anti-epileptic drugs such as lamotrigine, topiramate, levetiracetam, pregabalin, gabapentin, zonisamide, oxcarbazepine, and there are some new drugs. These are lacosamide, reticabine, parampenal, carbazepine acetate, and brivaracetam. And there are also some orphan drugs. These drugs only used in very special conditions, such as rufinamide, stripantol, and felbamate. And first of all, before starting treatment, we should diagnose correctly. This seizure or this attack is epilepsy, epileptic seizure, or not. The correct diagnosis is very important. We should aware of the situations that are confused with epilepsy, such as cardiogenic syncopes or sleep disorder. We should aware all these conditions. And we should make the seizure classification. It is the most important way to make seizure classification correctly, and then you should diagnose the syndrome, if possible, of course. And the first aim is control the seizure, to control seizure. And also we should control the side effects, and we should improve the quality of life of the patients. Therefore, epilepsy treatment is changed due to seizure type or epilepsy syndrome, or frequency and severity of the seizures, and the side effects of the treatment. And also, it is changed psychosocial problems of the patients. And also, we should consider the comorbidity of the patients. And we should also consider that the drugs patient use. And also we should consider the age of the patients and the sex of the patients. And we should know the pharmacological features of the drugs. First of all, the anti-seizure drugs, and also the other drugs that are the patient use. First of all, we should define the epilepsy. International League Epilepsy, International League Against Epilepsy defined epilepsy in 2014. I'm sorry, in 2014, and according to this epilepsy can be considered to be a disease of the brain defined by any of the following conditions. First of all, patients have at least 2 unproved seizures occurring greater than 24 hours. And 1 unproved or reflex seizure and a probability of further seizures similar to the general recurrence risk after 2 unproved seizures occurring over the next 10 years, or the diagnosis of an epilepsy, any epileptic syndrome. Epilepsy is considered to be resolved for individuals who are either had an age-dependent epilepsy syndromes, but are now past the applicable age and who have remained seizure-free for at least 10 years, and of anti-seizure medicines for at least the last 5 years. Therefore, according to this test, the seizure risk after these conditions at 5 years after 2 unprovoked seizures is 73%. The seizure risk is very important. According to this test, after 2 unprovoked seizures, seizure risk is at least 73%. If the patients have only a single seizure or only a first seizure, what we do? We should examine the patient. We should evaluate the patient. If the patient have abnormal neurological examinations and interictal discharges in EEG, structural lesion in neuroimaging, therefore the second seizure risk is higher and higher. Sometimes the patient and or family do not want to risk a second. In that time, we also start the medication. Therefore, after a single seizure, if patient wants, or if the patient has abnormal neurological examination, interictal EEG, interictal platform discharge in EEG, and the structural lesions in neuroimaging, we usually start treatment. What's the rule of treatment? First of all, we start with monotherapy. We should start only a one drug. And first of all, the dosage is low, and we should increase gradually, and we increase the dosage, maximum tolerated dosage. If the seizure persists, or if there are many side effects with the first drugs, we should start the second drug. Again, the second drug, it increased to the maximum dosage. After that, we should gradually discontinue the first drug. If the patient had no seizure control, therefore we add on any other anti-seizure drug. We prefer monotherapy. Why? Because monotherapy has no drug-drug interactions, and the side effects are lower in monotherapy, and it's also cheap, very cheap, and the patient compliance is better, and also it is usually enough for the seizure control. About 60% or greater than 60% patients have seizure control with only monotherapy. And we should evaluate the monotherapy before the initiation of second drug. We know that the person, after a first monotherapy, patients are usually seizure-free about 50%. After the second monotherapy, patient usually seizure-free about 10%. If we decide to continue with polytherapy, the first add-on drug, the seizure-free rate is only 5%. It's very low. After diagnosis of epilepsy, we should classify the epilepsy correctly. We usually used the epilepsy classification doing by International League Epilepsy and published in 2017. Seizure is mainly divided into three groups: focal onset, generalized onset, or unknown onset. Generalized onset seizure and unknown onset seizure had motor signs or non-motor signs, such as absence. And focal onset, if the patient has focal onset seizure, if patient is aware or not aware, it's also important. After that, if it is motor onset seizures or non-motor onset seizures, we should classify all the seizure type according to use these charts. According to our guideline, this is our guideline. I'm so sorry because it's Turkish, but the first column is a large spectrum anti-seizure drugs. We have many large spectrum anti-epileptic drugs. It means that we use these drugs in focal onset seizures or generalized onset seizures. These are the lamotrigine, levetiracetam, parampenal, rufinamide, topiramate, valproate, or zonisamide. And someone is a narrow spectrum anti-seizure drugs. These drugs is only effective in focal onset seizures. These are carbamazepine, acecarbazepine, and gabapentin, pregabalin, oxcarbazepine, phenytoin, such as. And another narrow spectrum anti-seizure drug is atoxicimide, and it is effective only seizures, absence seizures. And according to the International Epilepsy League special report, they advise us to use some drugs in some seizures. For example, if the patient is adult with partial onset seizures, we use carbamazepine, levetiracetam, phenytoin, and zonisamide, level A, and valproate is level B, and the other drugs. And if the patient is a children with partial onset seizure, level A drugs is oxcarbazepine. If the patient is older age, the first line is gabapentin and lamotrigine, carbamazepine, topiramate, and the valproate can be used. And another type of seizures, if the patient is adult with generalized onset tonic-clonic seizures, no level A and level B drugs, we use nearly all drugs. And if the patient is children with generalized onset tonic-clonic seizures, again, no level A and level B drugs. And if the patients with absence seizure, the first line treatment is atoxicimide and the valproate, level A, and the other alternative is lamotrigine. If the patient has benign epilepsy with centrotemporal spike, no level A drugs, no level B drugs, but carbamazepine and valproate can be used. Again, the same for juvenile myoclonic epilepsy, no level A, B, C drugs, but we know that the valproate is very effective juvenile myoclonic epilepsy, topiramate or zonisamide or maybe lamotrigine can be used. And this is for our guideline, and these are the epilepsy syndromes, and these are the drugs. It is nearly the same with International League Against Epilepsy. And if the monotherapy is unsuccessful, what will we do? We know that at least 60% of patient is responsive to the monotherapy. If it's unsuccessful, we should review the diagnosis. Is it correct or not? Sometimes some conditions are confused with epilepsy. For example, psychogenic non-epileptic seizures. For example, syncopes or movement disorders, sleep disorders, parasomnias, Therefore, we should review the diagnosis. Is it correct or not? Sometimes drug is not true. Anti-seizure drug is not true. For example, sometimes doctors don't use suitable drugs for seizure. We should use suitable drugs for seizure. For example, in juvenile myoclonic epilepsies, the most effective drugs, as we know, valproate, topiramate, maybe levetiracetam or zonisamide, but we know that carbamazepine may increase the myoclonic seizures. It is same for oxcarbazepine, acecarbazepine acetate, and pregabalin. These drugs are increased the myoclonic seizures. Therefore, these drugs are not suitable for juvenile myoclonic epilepsy. We should also consider the drug tracking. Patients may use many other drugs. Therefore, these drugs and anti-seizure drugs may interact with each other. And sometimes we cannot use the correct dose. We start the low dose and we cannot increase the drugs because of the side effects. We cannot increase the dosage of drugs because of side effects. Therefore, we should review all these conditions. And sometimes patient is wrong because, as we know, patient compliance sometimes is very poor. And sometimes patients prefer unsuitable lifestyle. They may use substance, alcohol, or narcotic drugs. Therefore, we should also review the patient condition. And if everything is okay, if the drug is okay and the diagnosis is okay and dosage is good and the patient is good, and the seizures are continued, we add another anti-seizure drug. But this drug has a different mechanism of action from the first drug. And we also prefer that this drug has different side effects profile from the first drug. And we should prefer rational polytherapy. What does it mean, rational polytherapy? The effects of drugs are complementary. They assumed as synergistic drugs. And usually we prefer the combination of these drugs with different mechanisms of actions. Therefore, we know that we should know the mechanisms of the drugs. Many drugs have different mechanisms. For example, phenytoin carbamazepine or oxcarbazepine and acicarbazepine acetate, lamotrigine, and lacosamide and zonisamide effect by the way of voltage-gated sodium channel. But levetiracetam effect vesicle protein 2A, synaptic vesicle protein 2A. For example, some drugs are gabage. Some drugs are only affect the potassium channels, for example, redigabine. Like this. And some drugs has multiple mechanisms of action. This table summarizes the mechanisms of actions of anti-seizure drugs. And these are also the mechanisms of action and the interaction between the anti-seizure drugs. We usually prefer this combination, valproate and lamotrigine, valproate, lamotrigine, and clobazam, carbamazepine and gabapentin, lamotrigine, valproate, and topiramate, valproate, topiramate, levetiracetam, and carbamazepine and levetiracetam. But sometimes we avoid some combinations of the drugs. These are phenytoin carbamazepine. Phenytoin and carbamazepine has the same mechanism, by the way of voltage-gated sodium channel. And also phenytoin and lamotrigine, carbamazepine, oxcarbazepine, carbamazepine, lamotrigine, gabapentin and vigabatrin, gabapentin and benzodiazepine, and topiramate and phenytoin, such as we should be careful. Because they usually, these combinations has usually the same mechanism of action. We should also consider the safety and tolerability of the drugs. Older anti-seizure drugs, usually safe drugs. And sometimes they may cause hepatic insufficiency, aplastic anemia, and severe allergic reaction. And in long-term use, there are some important side effects such as gingival hyperplasia, neuropathies, cognitive seizure disorders, and osteopenia. And vigabatrin caused permanent visual field defect. And we know that New anti-seizure drugs are better tolerated than the older ones. Not much more effective than the older ones, but better tolerated than the older ones. Hypersensitivity higher risk drugs are lamotrigine, phenytoin, carbamazepine, and the lower risk drugs, levetiracetam, gabapentin, pregabalin, and valproate. Some drugs may cause weight gain. These are mainly GABAergic drugs. And some drugs, such as zonisamide and topiramate, cause weight loss. And topiramate and zonisamide also may cause kidney stone. Therefore, we should be aware of all these drug side effects. And some drugs may cause liver enzyme induction. We know that phenytoin, carbamazepine, phenobarbital, and pyrimidone are potent liver enzyme inducers. And new anti-seizure drugs either do not have hepatic enzyme inducing properties or are only minimally inducing effect. And we should also review all the comorbidities. This table, I think this table is very important because according to some comorbid condition, we prefer some drugs and we avoid some other drugs. For example, if the patient has migraine and focal seizures, focal onset seizure, the first choice is topiramate and zonisamide, and the second choice is valproate and lamotrigine. If the patient has generalized seizures, generalized onset seizures, and migraine, the first choice of drugs are valproate, topiramate, and zonisamide. If the patient has depression and focal epilepsy, lamotrigine and carbamazepine, oxcarbazepine, and valproate can be used, but we should avoid levetiracetam and topiramate. And if the patient has depression and generalized onset seizures, we should prefer lamotrigine and valproate, but we should avoid again topiramate. If the patient has cognitive disorder, for example, dementia and focal seizure, we prefer lamotrigine, oxcarbazepine, and also zonisamide, levetiracetam, and valproate. And if the patient has both cognitive disorder and generalized onset seizures, we should prefer levetiracetam, valproate, maybe levetiracetam or zonisamide, but in both conditions, both focal onset and generalized onset seizures and cognitive disorders, we should avoid topiramate. And if the patient has psychosis and focal seizures, carbamazepine and the valproate is the best. And lamotrigine, oxcarbazepine, and pregabalin can be preferred. And if the patient has psychosis and generalized onset seizures, we should prefer valproate and lamotrigine and maybe zonisamide, but in both and generalized onset seizures and psychosis, levetiracetam should be avoided. If the patient has insomnia and focal seizures, we prefer pregabalin and gabapentin firstly, and if the patient has insomnia and generalized onset seizures, valproate, levetiracetam, topiramate, zonisamide can be preferred, but in both type of seizures and insomnia, we should avoid lamotrigine, especially not dosage. If the patient has obesity, in both type of seizures, we prefer zonisamide and topiramate, and levetiracetam and lamotrigine can be also preferred, but we should avoid the drugs that cause weight gain, such as valproate, carbamazepine, pregabalin, and gabapentin. If the patient has older age, and focal seizures, lamotrigine, gabapentin, levetiracetam can be preferred. And if the patient has older age and generalized seizure, we can prefer lamotrigine, valproate, and levetiracetam. If the patient has renal insufficiency and focal seizures, carbamazepine valproate can be used safely. Lamotrigine, oxcarbazepine, and pregabalin can be preferred. And if the patient has renal insufficiency and generalized onset seizures, lamotrigine, valproate, and zonisamide can be used. But in both generalized and focal onset seizures and renal insufficiency, we should avoid levetiracetam. And if the patient has hepatic insufficiency and focal seizures, levetiracetam, lamotrigine, gabapentin can be used, but we should avoid valproate, phenytoin, and carbamazepine. If the patient has, again, hepatic insufficiency and generalized onset seizure, levetiracetam and lamotrigine, topiramate, zonisamide can be used safely, but we should avoid valproate. In case of pregnancy and focal onset seizures, we can use lamotrigine, carbamazepine, and levetiracetam, but we should avoid valproate. These are very high teratogenic risk. And also we should avoid phenobarbital and phenytoin. If the patient has pregnancy and generalized onset seizure, we use lamotrigine and levetiracetam. Again, we have to avoid valproate, because valproate has very important teratogenic effects. And as a summary, before we start treatment, we usually wait second seizures. In special cases, sometimes we start to use anti-seizure medication in first seizure or single seizure, but usually we wait the second seizure. We will wait the second seizure. The main aim is to control the seizures and no side effects. And the most appropriate anti-seizure drug can be determined according to the seizure type, epilepsy syndrome, and comorbid conditions, and the drugs that are used by the patient. We should know very well the efficiency and the side effects of the anti-seizure drug. We start the treatment with single drug as a monotherapy. We start low dose and increase the dosage to maximum tolerated one. If the seizure persists, or if we cannot increase the dosage of the first drug because of side effect, we change the drugs and we try the alternative monotherapy. We start the second drug and we increase the dosage of second drug to maximum one. After that, we gradually discontinue the first drug. If again no seizure control, we review the wrong diagnosis, wrong dosage, wrong drug, wrong patient. After that, if the diagnosis is correct, the drugs and the dosage are correct, or if the patient is correct and no seizure control, we start to add on treatment. We know that about 20 or 35% of patients with epilepsy has resisted to treatment. In that cases, we should keep our mind alternative therapeutic options, alternative treatment options, except drugs such as epilepsy surgery, neurostimulation, or ketogenic diet. Again, I want to say, if the patient no response to treatment, please review the diagnosis, drug interaction, patient compliance, and seizure triggers. And I try to briefly summarize the anti-seizure drug monotherapy. And this is my town, Akyaka, about 20 kilometers to my university. And this is very beautiful place. And thank you for your attention. And see you in some congress or some meeting.